Good morning, Professor Lucas.
Good morning.
You're going to be asked questions by Miss Thompson, counsel to the inquiry, whom I think you have met. Before that, would you raise your hand and say the words of the oath after me? I swear by Almighty God.
I swear by Almighty God.
That I will tell the truth.
That I will tell the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Miss Thompson.
Good morning, Professor. What is your full name?
Sebastian Brendan Lucas.
May I ask your age?
I'm 75.
And you are a recently retired consultant histopathologist.
Yes, I retired. I took off my gloves last October when my GMC registration would have to be renewed at great cost.
Before I ask you more about your career to date, can
Yep.
I ask you to open up the blue folder that's on the table in front of you? There are various documents in there that you might find it helpful to refer to when you're giving your evidence. So we'll begin by having a look at what's there. There should be a letter of instruction that you were sent by the Crown Office on the 29th of May of 2018 with the reference number COPFS 02468.
Yeah, hang on. Yeah. Sorry, I'm just puzzled by the phrase letter of instruction because I don't see it here, but I mean, there obviously was one sometime or other. What am I looking for? That's my CV. That's my first report.
It may not matter because all
Yeah,
of these documents, if we need to look at them, we'll bring them up on the screen in any event. You mentioned having, as you flick through the folder, looking for the letter of instruction, having come across your CV. Is that in there?
Yeah.
And also the report that you prepared
Yeah.
for the Crown. Is that also in the folder?
Yes, there are two. One from 2018 and one more recent. Yep.
When you say there's a more recent report, are you referring to the statement that you gave to the inquiry?
Yes, the one with the Shekel Bear Inquiry badge on the top.
I see. So we've got your CV and the report you prepared in 2018 and the statement that you gave to the inquiry.
Yep.
That's grand. What we'll perhaps do is bring up the inquiry statement on the screen, please. It's got inquiry reference 00314. This is a copy of your statement. We can see that it was taken on the 8th of December of last year.
And modified subsequently a bit.
Yes, yes, that's part of the normal procedure. And if we go to the very bottom, please, of the statement, we see that the final paragraph 64, reads, I believe the facts stated in this witness statement are true. I understand that the statement may form part of the evidence before the inquiry and be published on the inquiry's website. And in that knowledge, you went on to sign every page of the statement. Is that right? You'll see that your signature has been blacked out on the screen, but I'm hoping that there will be a copy of your signature on the hard copy in your folder.
There is. It's here in front of me.
You can refer to any of these documents at any time. If there's anything that I want to take you to, it will come up on the screen. But if you would find it helpful to refer to your report or your statement or indeed your CV, you can do so. And if there's anything that you'd like to put up on the screen, then just let me know.
Okay.
Let's begin with your experience, your qualifications and your career. Can we return to the beginning of your statement, please, and bring up paragraphs 2 and 3. You give your formal qualifications at paragraph 2, which include a medical degree and a fellowship of the Royal Colleges of Pathologists and Physicians.
Yep.
And at paragraph 3, you say, I've been a consultant histopathologist since 1980, with wide experience in general diagnostic histopathology and autopsy pathology. I've been a member of the Royal College of Pathologists from 1978 and a member of the Royal Colleges of Physicians since 1975. I've published widely on all aspects of histopathology and autopsy practice, particularly in infectious diseases.
Yep.
So you explain that you've been a consultant histopathologist since 1980 until the autumn of last year when you retired. In very general terms, what does the work of a consultant histopathologist involve?
It's all to do with diagnostics from looking at people's tissues. Therefore, it's different from looking at blood or looking at cultures and infectious diseases and so on. And it really divides into three forms. There is histopathology, which is samples of people taken from living or dead people. There is cytopathology, where you scrape or obtain superficial layers of cells from various organs. And then there is autopsy pathology, which is the gross examination of people who have died. That's divided into forensics, which is suspicious deaths, and everything else, which is not. And that also involves using histopathology in a proportion of cases. So there's three lines of what we call histopathology.
And you explain in your statement that general diagnostic histopathology and autopsy pathology were your particular areas of practice and expertise.
Cytopathology was invented after I trained, so I missed all that.
I see.
Yes, I've been doing diagnostic histopathology, and latterly, certainly for the last 10 years or so, I've mainly focused on autopsy pathology and given up routine live patient diagnostic histopathology. That's when I turned 65 and decided to stop doing that.
And so far as autopsy pathology is concerned, am I right to understand that you're not a forensic pathologist?
Yeah, no, I'm not.
And so the deaths that you would be involved in would not be suspicious deaths?
In principle. In actuality, it's not quite so simple, because for decades I've been involved in looking at some aspects of people who are dead, people who have died under, in a sense, forensic circumstances, asked by forensic pathologists or coroners or lawyers whether I can contribute anything useful to the evaluation of those deaths. But I'm not on the Home Office register as being a proper forensic pathologist, so I'd never be asked directly, or I would never have been asked directly to look at someone who'd been murdered or thought to be murdered. There's one big exception to that, is that I got very much involved in a complicated murder investigation in New Zealand, but as far away from where we are sitting as possible. And the only reason I got involved in the evaluation of that is that when I looked at the material, I realized that this poor child had not been murdered, had actually died of AIDS, HIV/AIDS, of which I had been an expert, and the unfortunate medical and pathology staff of New Zealand hadn't realized what AIDS is, because they don't have any, and they thought the kid had been murdered. And I could prove in court that in fact the child died of AIDS and there was no forensic aspect at all.
Thank you. Where were you in practice as a consultant?
Where?
Yes.
In 1980 I was actually in Nairobi in Kenya, but then thereafter University College Hospital and St Thomas's Hospital. Actually, those are the two main places I have been based at, with an additional year spent in West Africa working on HIV about 30 years ago. But essentially I've been London-based.
Can we move to paragraph 5 of your report?
Yep.
Sorry, your statement, I should say. You explained that you became a professor of pathology in 1995 at Guy's and St Thomas's Hospital, retiring in 2012. From 2012 to 2022, I worked part-time at Guy's and St Thomas's Hospital and also local mortuaries in Milton Keynes, Bedfordshire, Luton and Buckinghamshire. I stopped practical working altogether in October 2022. Since then, I teach pathology trainees on autopsy pathology interpretation by lecture, and I lecture to medical students on general pathology, and I review autopsy pathology cases at the request of coroners, pathologists, families and legal firms. So you were also a professor of pathology, and I wanted to ask you to explain the difference between your work as a consultant and your work as a professor.
They overlap. I'd been a consultant, and I was a consultant in those hospitals. The professor bit wasn't a personal chair, it's a substantive chair. There were, the medical school had a position called Professor of Pathology. In fact, it says Guy's and St Thomas's, that's where I started. Within 3 years, King's College Hospital also got in on the act, and then King's College London became the lead medical school. So it's actually 3 medical schools over those, which are about 2 or 3 miles apart in southeast London. I was the Professor of Pathology, and when I stopped being that in 2012, I have not been replaced because medical schools don't like professors anymore, because they regard us as not productive on the research assessment exercise, which is generally true. We're much more practical rather than research orientated.
I see. So from 2012 to 2022, what was the nature of your work at hospital? Was it still in a consultancy role?
Yes, I mean, my colleagues, my friends and colleagues over many years would always show me problem cases, and I would tell them what I thought the answer was. But the responsibility for the correct answers were theirs. What I was actually doing most of the time was doing coronial autopsy work. Now, you know that the the England and Wales coronial system is very different from the procurator fiscal system here in Scotland. But in England and Wales, we look at something like 14% of everyone who's died, mainly because no one knows why they died. And that was what I was doing in St Thomas's, Milton Keynes, Bedford, Luton, and Buckinghamshire, which is Stoke Mandeville Hospital, because that's where I live now.
So those were autopsies that you were requested to perform by the coroner.
By the coroners.
But were these non-suspicious deaths, or?
Oh yes, they've been by definition. I mean, if it was a prima facie homicide case, I would never be approached. But interestingly, and you may have the same problem in Scotland, there's a sort of curious border between forensic and non-forensic. And if we call them coroners, but it might be the fiscals in your case, and slightly worried about a case, whether it might or might not have medical legal implications, they would often ask an experienced pathologist, and they'd pick on me, to look at it and to stop if I thought there was any malfeasance going on, because I'm cheaper than the forensic pathologist. You know, there's a huge pay differential in autopsy work between routine, medical and forensic, about a 10-fold difference in remuneration. And that has quite an impact on who you ask to look at things.
I see. And as part of your work carrying out autopsies for coroners, would you require to reach a view as to the cause of death and issue a death certificate?
Oh yes, that's what we're there for. Yeah.
It's simply that you wouldn't be instructed in a case that, on the face of it, arose from suspicious circumstances. No. Can I ask you a little about your experience as an expert witness? You mentioned in paragraph 5 being asked to review cases, not only for coroners, but also for pathologists, families and legal firms. How many medical legal cases have you been involved in over the years, can you say?
Well, it drops off. I mean, and having retired, I can tell you, it is amazing how quickly you become yesterday's man and people forget about you. But until that point, I was regarded, and I'm not being immodest or arrogant, it's simply true, as in Britain, the person who knows most about the morbid anatomy and the pathology of 3 things. One was infectious diseases, which includes HIV, which HIV made my career, I have to say, because it happened about the time that I happened as well. Second one was maternal mortality, and I made St Thomas's Hospital the maternal autopsy centre for southeast England rather, and had a huge experience. And then I also, and relevant to this inquiry, took on an interest in sickle cell disease, morbid anatomically, because most pathology of sickle is only seen, sadly, when people with sickle trait, which is very common, and sickle disease, which is much less common, it's only seen when they die. Biopsy samples in life are not normally taken from people with sickle, apart from the kidney, which is sampled for practical reasons. And I got into sickle, and to anticipate your question, at the suggestion of a haematologist at King's who was a sickle who was lamenting the quality of autopsies performed on his sickle patients by all the other pathologists in the area, who, he said, had no idea what they were looking at. And I just thought that was an interesting challenge, so I took it up. And that's exactly the same reason I got involved in maternal mortality. Some local obstetricians were very annoyed by the inadequate autopsy evaluations of the fortunately few people who do die in pregnancy and delivery. And someone said, would you like to look at it and take this one on as a speciality? And I got absolutely fascinated and did that. And I still review those cases, but I don't, as I say, do any more autopsies directly myself because I can't legally. I'm off the register.
So in terms of your medical legal practice then, how many reports have you prepared in cases where sickle cell has been relevant?
The last count of my folders, I had looked at more than 100 people who had died with sickle cell disease. I've looked obviously at thousands of people who have, no, that's unfair, a lot more people who've had sickle cell trait because it is common, and as we're going to discuss in great detail, sickle cell trait is mostly harmless.
But in terms of your is that in terms of your medical legal practice, or is that your work more broadly as a clinician and in terms of your autopsy work?
These are autopsies that I've done myself and cases that people have asked me to review because of my known expertise.
All right. So you've been involved in more than 100 cases involving...
That's sickle cell disease.
Sickle cell disease,
Yep.
either as the pathologist
Yes,
or,
mostly as pathologists,
or as a reviewer.
and about a quarter of them will be other pathologists or coroners saying, will you please look at this and tell me what you think is going on?
And how many cases have you been involved in that concern sickle cell trait? Can you put a figure on that?
Sickle cell trait, pathologists occasionally sent me saying, no, I can see sickle cells here, do you think this is relevant? And once it's established as sickle cell trait and there is a perfectly reasonable alternative cause of death, I say the sickle cell trait is irrelevant, which is the general rule. And as all the sickle societies will emphasize, having sickle trait means you have a normal lifespan unless some critical things happen, which we will no doubt come to.
We will discuss those in detail later this morning, but I'm interested to know whether you can put a figure on the number of sickle cell trait cases that you've been involved in over the years.
Well, interestingly, the important sickle cell traits cases I have been involved in, and this is directly relevant to what we're talking about today, are people who have died in custody. That's why I know about them. And I produced and gave you a list of 8, I think, that I have been involved in, including Mr. Bayo.
So you've been involved in at least eight cases
Yeah.
involving sickle cell trait,
Yeah.
where the deceased died following contact with police or in police
Or
custody.
prison.
Or
Police
prison.
arrest, cells or the prison service or deportation centres as well, which is kind of the same thing.
Returning to your medical legal work more generally, you mention in paragraph 5 of your statement being instructed by coroners, also being asked to review cases by pathologists. You mention families and legal firms. By and large, who do your instructions come from? Are they in civil cases, in criminal cases for the coroner?
They're probably equally distributed, actually, across that source. As I say, it's drying up now. You get forgotten about.
So civil work as well as criminal work?
Very little. If you regard death in custody as criminal, okay, then that's part of it. But most of it is not, actually. Most of it is medical. Yeah.
And have you given evidence before?
I have given evidence in coroner's courts enormous numbers of times in 1 or 2 high court trials on medical negligence, none of which involve sickle. And that's about it, actually. I mean, I always work on the principle, if it's a contested civil case, that it's up to the lawyers to sort it out before we go to trial, and they normally do.
And have you published over the years?
Yes, I publish less on sickle than I have on all the other things I've been interested in. What I have done is lecture a lot on it, but I did produce for the College of Pathologists a set of guidelines on how pathologists should address a sickle disease and also mentioned sickle trait autopsy. This is really to try and improve autopsy standards nationally. And I've written 1 or 2 papers on some aspects of sickle cell pathology, all of which derive from autopsy work, I may say. The only in-life pathology interest in sickle, really, that matters is kidney disease, because people with sickle cell disease can have very bad kidney disease. But apart from that, sickle pathology is a sort of unknown territory to most pathologists.
Can we look at paragraph 4 of your report, please?
Paragraph, sorry?
4.
Yeah,
It will come
okay.
up on the screen, and you have the hard copy too.
Oh, yes, yeah.
Also in the late 90s, I've taken a special interest in the morbid anatomy of sickle cell disease, and you mentioned that a few moments ago in your evidence, Professor. I've done around 100 autopsies now on individuals with sickle cell disease and autopsies on uncountable numbers of individuals with sickle cell trait, because trait is so common. I've been involved in medical legal court work on many sickle cell disease deaths, and specifically 5 previous deaths in custody or stress-related deaths among men with sickle cell trait. I think you said that number is perhaps
I think
now
it's 8, actually. I'm not quite sure why I wrote 5.
rather
Yep.
than 5. And you've explained to us how your interest in sickle cell disease and trait developed over the years. How have you developed that interest in practical terms? Is it your autopsy work, or is it the diagnostic work? What allows you to develop that interest?
Yes, that's a very good point. How do you get good at anything is, this is my Lucas's very simple rule for people who want to be experts. Say that you are, and then people will start sending you problem cases and you learn on the job. It really is as simple as that. And after a while, you realize you've seen more than anyone else. And people realize that. It sounds arrogant, but it's absolutely true. People who want to be lung cancer experts simply declare, that's what I'm going to do, and then the difficult cases are sent to them, and they get better and better at it and sorting them out. And so, in sickle and in HIV and in maternal mortality, I passed the word to the coroners in the area of southeast England to say, if you have a case that a patient who has one of these things and requires a coronial autopsy, please, emphasize the please, send it to us at St Thomas's and we will do the job for you. And so I managed to build up a large collection of experience on these things.
Are there
And
many?
I had to say also that the coroners are quite grateful because they realise it'll be sorted out better than their local pathologists, simply because I've seen more. And the pathologists are quite grateful because it means they haven't got the problems of trying to sort out these difficult cases, so they pass them on. And we never charge very much money.
Are there many specialists in the UK with an interest in sickle cell?
Sickle, 0. I have succession planning is important. The HIV and the maternal work is sorted out, and I approached one of my younger colleagues at St Thomas's to say, would you take on the sickle cases coming in for coronial autopsy? And to my pleasure, he said yes. I said, read the guidelines, show me your first few, and just get on with it and learn on the job. And he's doing well. And that's how you do it.
I want to ask you some questions now about sickle cell
Yeah.
disease. Can you explain to the chair, can you help us to understand what is sickle cell disease?
Sickle cell disease happens in people who have 2 chromosomal abnormalities on the same allele. I can't even remember which chromosome it is now, and it really doesn't matter. It means that their hemoglobin A is abnormal because they got both genes wrong, one from the mother, one from the father, and it means that the red cells being produced in the bone marrow have a very short life expectancy. Normal red cells that people who have not got sickle cell disease or thalassemia, but we're not worried about thalassemia today, should last about 100 to 120 days in the circulation before they're basically worn out and they're phagocytosed and taken away. In sickle cell disease, the red cell lifespan is something like about 8 or 10 days. It depends very much on the concentration of hemoglobin A, hemoglobin sickle, and others, because hemoglobin is quite complicated. So every person with sickle cell disease is different. It's not a uniform process, but you can talk about it collectively in terms of probability. And until about the 1980s, medical management of people with sickle cell disease was not very good, and most people across the world who have sickle cell disease did not make 20 years. They died within the first 2 decades of life. That has completely changed. We got prenatal diagnosis, we got natal diagnosis, as I'm sure you know, so we know everyone who's got sickle trait or sickle cell disease or thalassemia. We have medical management processes in Britain, which I think are better than most other countries, certainly better than America. And people now live to a good age. And so the average age of death of people with sickle cell disease from sickle cell disease has gone up to 40, 50, 60, 70. And we are now in the very interesting era, rather like we are with HIV, of looking at the impact of a chronic process going on, sickle, managed medically with old age. But that's not our concern here today.
So how is sickle cell disease managed then?
It's managed by specialist hematologists. It's very focal in Britain because the epidemiology is important. Most people with sickle cell disease live in London, particularly southeast London and West London, and Birmingham and in Manchester. But in many other places, there's no one around at all. And so that's where the expertise is concentrated. And I was very lucky being at Guy's and St Thomas's and King's to be in the epicenter of sickle in Britain.
Can you help us to understand why it is that there is this particular demographic in London as far as sickle cell disease is
Christ,
concerned?
that's called immigration history. I don't think we need to go into that.
But is sickle cell disease associated with being of a particular background or race?
Most people with the sickle gene arose evolutionarily, in fact you can use that word, somewhere in West Africa and spread as people spread. And the current belief, which I have no reason to contest, is it conveyed an advantage in defense against malaria. If you had the sickle gene and even sickle trait, you have some protection against having a severe infection of malaria and dying. So in that sense, it was successful. Unfortunately, sickle cell disease is itself not nice. Most people in the world with sickle cell trait or sickle cell disease are from Black Africa, to use the term very generally, particularly West Africa. There are others as well, but I'm sure you know that occasionally white people, blonde people, non-black people get sickle, particularly in North Africa, Tunisia, Libya, around there. India also has a lot of people who are not African origin with the sickle gene, and it stretches through the Middle East as well. But the great majority have a direct link with Black Africa.
Can a person with sickle cell disease who's receiving appropriate professional medical treatment lead a fairly ordinary life?
Yeah, yes and no. It's not a nice disease to have. The treatment is, I don't treat people with sickle, and I'm therefore relying on what I know from what my colleagues tell me and what I read. It is medical. There's a medical treatment. You can take a drug called hydroxyurea, which has an interesting effect on the type of red cells produced in the bone marrow, which is beneficial. Regular blood transfusions to keep the hemoglobin level up. Prophylaxis against significant infections such as pneumococcal sepsis, which is a particular predilection for people with sickle cell disease because they've lost their spleen usually, and you need the spleen to protect against pneumococcal. So there's penicillin or other antibiotics and vaccination. And in children, regular examination of brain blood flow. Sounds slightly odd to say that, but you can do that using Doppler technology. It's not invasive at all, just to predict those people who might be more likely to have a sickle-related stroke. And all these, and general good medical attention, just being seen by a doctor and a practice nurse is a very good thing. And as a result, life expectancy is shot up. And now it's unusual for young people to die of sickle cell disease in this country. back in West Africa, I'm afraid it's the norm.
Will a person with sickle cell disease enjoy good health?
Well, yes, except they're going to have to go to the clinic for a top-up transfusion, going to have to be seen quite often. It's a lot of regular outpatient and occasional inpatient. And then if the patient has a sickle crisis, which is often a painful crisis, they're going to be admitted to hospital with a standard regime of painkillers, often opiates, blood transfusion and general management, and then they go out. And many sickle patients are having regular crises, like sort of monthly or bi-monthly or sometimes even weekly, and no way can you say their life is normal.
What is a sickle crisis?
It is an event caused by sickling in critical organs, particularly the bone and the lung. In the bone, it causes the bit of bone to die, which is incredibly painful. So that's a painful sickle crisis, affecting arms, legs, other bones as well. In the lung, and we'll be coming to this in relation to sickle cell trait later on today, it causes the blood vessels in the lung to block up for one reason or another and produces an acute chest syndrome or an obstructive problem in the lungs, which means that the cardiovascular system doesn't work and they're in great risk of actually of dying.
What would cause a sickle crisis?
Well, yes, lots of things. Dehydration is an important one, because if a person is dehydrated, then the concentration of sickle abnormal cells in the blood goes up. Change in the acidity or alkalinity of the blood, a coexistent infection at the same time, operations, immobility, and probably stress. But there are multiple factors. But that said, most of the sickle crises, particularly in younger people, just come out of the blue. They just happen. And the sickle doctors are well aware of this. There's been a great problem until I think things have got better in the last 20 years, is that a sickle patient presenting to a hospital which simply doesn't see it, they won't know what to do. But now the word has spread, and haematologists are much better at sort of taking these patients and looking after them properly.
You said that a sickle crisis can be a painful event.
It's very painful and can be fatal.
And can be fatal.
Yeah.
And it would require hospitalisation.
Hospitalisation and specialist care. This is not something for, ordinary doctors to tackle, because they won't know what to do. Although there are, of course, guidelines now. Again, everything's much more regularised, and you can look it up instantly. What do you do if someone's got a sickle crisis? You do A, B, C, D, and then as a sort of start off, and then ask for specialist help.
And why might a sickle crisis prove fatal in an individual? A bone crisis, where a bone infarction is very painful of itself, is not going to kill you. The main cause of death is going to be cardiovascular, and it involves particularly the lung. And if blood, as you know, circulates around the body, goes from the heart, the right side of the heart, to the lungs, becomes oxygenated, comes back to the heart, the left side pumps it out under a high pressure, and it then supplies blood and everything else to the rest of the body. In the lungs, if that circulation starts blocking off because the sickle cells, which themselves, it's sort of the red cells sickle, and they sort of knot together to form an obstruction in the smaller bits, it can simply bring the lung circulation to a halt. And if the lung circulation is brought to a halt, the heart stops. It's as simple as that. And that's called an acute chest crisis. And it has a characteristic clinical presentation, a characteristic X-ray presentation, and if you see it under the microscope, sadly if they die, a fairly characteristic pathology appearance as well. So what would you see then in the red cells when sickling occurs?
I'm not sure how much you've had on this sort of basic physiology of sickle, but red blood cells are round, biconcave, so they've got little dimples on either side, and they're sort of 10 microns across. In sickle, because the hemoglobin in the sickle cell polymerizes and fixes itself in a different arrangement, it actually means the cells lose their round contour and they look like sickles and bent and longer with pointy ends, and they are rigid. The point is they don't bend like ordinary red cells bend, so they're going to block up small blood vessels really quite quickly, actually. And if that happens in the lungs and is not managed and sort of reversed fairly rapidly, it can be fatal. And as we will come to, this can happen exceptionally in people with sickle cell trait as well as sickle cell disease, but is much, much more common in sickle disease.
Well, let's move on now to sickle cell trait. You've explained what sickle cell disease is. What is sickle cell trait?
Well, I mentioned that you have sickle cell disease if both alleles of the critical chromosome have the wrong hemoglobin A. And you've got one from the mother, one from the father. In sickle trait, one of them is normal, hemoglobin A, and the other one is hemoglobin S, sickle. So instead of having hemoglobin SS, which is sickle cell disease, you have hemoglobin AS, A being normal and S being sickle. So it's a sort of halfway house.
And how does that differ then in terms of the way that a person can live their life, depending on whether they have the full disease or whether they have the trait?
There are something like, I looked it up once, at least 300 million people with sickle cell trait across the world. And in this country, something like 1 in 78 newborns has it, because we have an ever larger immigrant population. That's national average, obviously. Different places have different rates. And the huge majority, the vast majority of people would A, not necessarily even know they had it, and B, will suffer nothing. But there will be certain circumstances where that is incorrect and there are problems.
Okay, so you say that in the majority of people suffering from sickle cell trait, the individual won't know that they have it.
Yep.
And they
don't
won't
need to do anything different in their lives at all.
And it will have no effect.
Correct.
Are there circumstances in which a person with sickle cell trait may find themselves unwell as a result of having that trait? And can it, in fact, in some circumstances, be life-limiting or have the potential to cause death?
Correct.
In what circumstances?
Let's leave out the police custody business. The most important contribution to this whole area of where sickle cell trait can impact on life expectancy has come from two sources. One is from military recruits, particularly in America, and secondly from sports. In other words, high stress and high strenuous exercise. I can take you to, as a very famous paper written by John Kark, published in 1987 in the New England Journal, which I'm sure you've seen the reference of, looking at why American Army recruits die. And they looked at many, many years' worth. They looked at millions. This is huge epidemiology databases. And they looked at when military recruits, who are a large proportion of which are black, as we know, or a significant proportion are black, and they compared them with white people. Now, white people have normal hemoglobin AA. The black people here, a proportion would have hemoglobin AS. None of them would have had hemoglobin SS sickle, because if you had sickle cell disease or SS, you wouldn't be admitted into the army. But AS was an admission. That's an American thing. In Britain, we did it slightly differently. Come to that later. And they looked at why they died, taking clinical stories, autopsies, and everything else. And it became quite evident that when soldiers died, you could weed out the ones who had a natural disease, who had been murdered, who had had accidents and drug overdoses and all that. You take them out. And you just look at the soldiers who died who had no obvious cause of death. They just died. And statistically, it was an extraordinary discrepancy in looking at the populations just in black people who are AA, normal, versus AS, sickle trait. And the AS sickle trait soldiers who died with no obvious cause were, as epidemiologists say, grossly overrepresented in terms of the numbers. There was a huge relative risk of about 30. So if you were a recruit in the American Army and you died, then that's the wrong way of putting it. If you recruit in the American Army, there was a 30 times greater risk of dying if one had sickle trait compared to having normal hemoglobin AA. And this is among the black ones. The white soldiers, again, there will be a small number of unexplained deaths. But AS was grossly overrepresented. And Clark and colleagues and the American Army are extremely interested in this. They're trying to work out why this happened. And when you drill down into what had actually happened when these people died, it was on exercises where the soldiers were working basically in high temperatures and dehydrated. And the prime recommendation coming out of those reports was not stop exercises. You can't do that because armies are based on exercises, but please make sure that the recruits are adequately hydrated, giving them drinking water. And that turned the corner. The rate of deaths, these unexplained deaths in sickle trait soldiers, trainees, dropped.
Okay, so you mentioned military recruits and also sports
Yes.
in association with strenuous exercise.
Now the sports is derived not from mass epidemiology, but from individual case reports, because you don't get thousands of marathon runners together and do things. And there were lots of case reports, and there still are occasionally, of people with sickle trait working out. And again, it comes down to heat, exhaustion, dehydration. Marathon runners, things like that, just simply dropping dead. And the conclusion was, and when you did the autopsy, they had the acute chest syndrome. And it has to say that the particular focus on the chest syndrome came from looking at individual cases of mainly sportsmen, because they were going to be looked at very carefully, whereas Clark didn't go into the details of the pathology in his review of millions of people. And so it became quite evident, and this is the 1990s, we're talking about, that a small proportion of athletes with sickle trait undergoing extreme stress and in hot and dry circumstances had a risk of dying, and they died of the acute chest syndrome. In other words, although they had sickle trait and not sickle disease, they had enough sickle gene in their red cells for the red cells to sickle, block off the lungs, a result of which they died.
Is that what's meant by acute chest syndrome?
Acute chest syndrome, ACS. It's one of those standard acronyms in haematology.
So papers were published by Clark in relation to military recruits, and in the 90s in relation to sports and strenuous exercise. Yeah. And where did these reports take medical understanding and medical thinking around the risks to a person who lives with sickle cell trait?
Well, it had an impact on how military recruits are treated. And I in fact, in about 2005, the British Army asked me to go and talk to them about sickle trait in their recruits, because we have a lot, particularly people coming from the Caribbean islands. There's a large number of recruits into the British Army. Well, there were then anyway. And should they be excluded from admission? And I think the RAF did exclude, I don't know whether it still does, potential pilots if they got sickle trait. But anyway, the Army didn't exclude them, and they were learning from the Americans, and I just talked generally about the epidemiology, the pathology, and just the general recommendation is particularly on hydration, and just be careful. And I suppose also that if a soldier who happens to have sickle trait is feeling very unwell on an exercise, don't make him carry on, or her. Stop. And do something. I think that was another lesson actually came out, and the sort of the bullying thing. You push yourself harder and harder and harder. Don't do that because it can be dangerous. And from the military and from the sports information, this sort of information, this dripped down into practice. I don't know what the current guidelines in the army are now at all. You probably are better informed than I am. But it's really just common sense stuff.
And in the cases in which autopsies were performed, certainly in relation to the sports people, acute chest syndrome was found to be
was the
cause of
common
death.
factor, absolutely.
The common factor.
Yeah.
And in the military exercise, were autopsies carried out too, or was this a desktop review of deaths sometime later?
They are, and I have experience of that in a case we may discuss of a soldier who died on exercises in 2002, I think, or might have been earlier, who died of acute chest syndrome on exercises in a very hot summer up north, or actually south of here, sorry.
So in both studies then, the military one and the individual studies in relation to the sports people, there were autopsy findings that were consistent with the acute chest syndrome.
But it's an interesting point about you might think that one would learn lessons very quickly from autopsy findings. Not so, because how is the information going to be broadcast? One of the defects of the England and Wales coronial system is that the autopsy report is private. It belongs to the coroner and no one else. And in an awful lot of cases, it's not just relating to sickle, but lots and lots of other circumstances as well, where you think, wouldn't it be a really rather good thing if these reports were collectively published so people could read them? But no, that's against the law. But enough collections and talking about these things and meetings and looking at cases and once a pathologist has come across one of these cases, they don't forget it. And they'll remember that, so the next time it's easier for them to evaluate. And we all learn on the job, frankly.
Can you help me to understand the mechanisms that are at play here and how it is that exercise, high temperature, dehydration, exhaustion in a person suffering or a person who has sickle cell trait can result in a sickle crisis, acute chest syndrome and death? What is the mechanism?
Well, let's just go back to the basic, simple physiology. You've got a volume of blood in which, with red cells in, excuse me, and both in sickle cell disease, where you've got SS and sickle trait, we've got A, normal, S, in the red cells. There will come a point, if you stress that blood, that the cells will sickle. What are those stresses? Temperature, high or low. Dehydration, in other words, the concentration of the sickle hemoglobin goes up. Acidosis, that is the pH, drops. I mentioned dehydration, yes. And it is not so difficult to see that you can get into a situation where these factors come together. It's multifactorial, and there's a tipping point at which the cells then suddenly sickle. And in every person, it'll be a different tipping point, a different threshold for these various promoting factors. And sickle cell disease is quite easy to see how that can happen in a sense almost spontaneously, because they have got no normal hemoglobin. Sickle trait people are protected because they've got one allele which is A, one which is S. But there will come a point, or can come a point, where these various factors make the blood sickle.
And are you able to help us to understand what it is about these factors that causes the sickling of the blood?
Well, it's concentration, it's temperature, it's pH, acidity. Just stick with those three. There will come a point in anyone or anyone's blood which contains sickle trait where you can make it sickle. And the question is, how much stress is required to actually make it sickle? Everyone will be different, which is why obviously in sickle trait, these events are very, very uncommon, but they can occur. And it is biologically very plausible, and you could make it happen experimentally.
What about oxygen? Does hypoxia
Oh,
play
yes,
a
sorry.
part?
Thank you. Hypoxia, yeah. No. Lack of oxygen, temperature, concentration, acidity, oxygen concentration. Thank you. Those are the four.
Will they always work in combination, or could one of these factors alone take a person to tipping point?
I don't know.
Can't say.
It would be sensible to say it all kind of goes together as a package, but each individual person will have a different trigger level for these various factors doing it.
So when these 4 factors come together, concentration, temperature, high or low, pH and oxygen, in a person with sickle cell trait, they may reach tipping point where they have a sickle crisis.
The acute chest syndrome happens and the lung circulation is compromised, or stops.
So should we understand that it's exactly the same course of events, as it were, as you would see in a person with sickle cell disease,
Yes.
but the tipping point is so much higher in a person who only has the trait?
Very well put.
But once that tipping point has been reached, they will experience the same crisis, the same acute
Yes,
chest,
they would, that's
and
right.
potentially the same fatal consequences as a person with full sickle cell disease.
That's right. And of course, once it starts happening, it's going to get worse, because if the circulation in the lung is compromised because of sickling, by definition, the blood is going to get more acid because it's not circulating. By definition, the oxygen concentration is going to go down because it's not being reoxygenated by the circulation through the lungs, and so on. It just makes it worse. So it becomes an irreversible process. But there will, of course, be a point where you could reverse it quickly.
Yes. So before that tipping point that you've mentioned is reached, then the crisis, well, I suppose before it gets to the crisis, the process could be reversed. And would that require medical treatment, or could it be as simple as having a glass of water and taking a few
getting
deep breaths?
out of the sun, yes, exactly, and stopping exercising. Because when you do strenuous exercise, whether it's part of a sports program, part of an exercise, or running away from the police, and I have seen this in 1 or 2 cases, the muscles are extremely active, and what do? They produce lactic acid because of anaerobic metabolism. So strenuous exercise is sort of pro-acidotic feature, because that's what muscles do. It's their normal physiology.
You mentioned that hypoxia is one of the 4 contributors.
And that's why pilots in some countries are not allowed to be sickle trait. So the other way around, you can't be a pilot if you're sickle trait, because up in the stratosphere, the oxygen concentrations are less than they are on the surface. And occasionally there do appear to be pilots who are sickle trait. I've seen reports who have suffered a sickle crisis and died. But as I say, in Britain, I don't think we let pilot trainees be sickle trait.
And if I can digress for a moment, you did say earlier that a person living with sickle trait might not know that they have it. Clearly, pilots are screened, and I think you mentioned newborn babies are screened nowadays.
They are
that
in
right?
England and Wales. I have no idea. I'm pretty sure they must be screened in Scotland. There's a UK programme, and it started up within the last 20 years. It's done as a sort of part of the Guthrie test. When a baby is born, heel prick blood is taken and is screened for loads of things, and they added on sickle and HIV, by the way, sometime in the last 20 years. And that therefore goes into the GP records, and so on and so forth.
And a person over the age of 20 then, who perhaps hasn't been screened as a newborn.
Or an immigrant coming in.
Yes.
Absolutely. No reason why they should have been.
Could be living with it and not know that they have it.
Oh, yeah.
And would it be reasonable to assume that unless they've had some form of ill health or crisis that has resulted in them getting medical attention, then there might not be anything in their medical records one way or the other?
Yeah, that's right. I mean, a lot of us have blood tests for one reason or another, but there's no particular reason why a sickle screen would be part of a routine, non-programmed one. Yeah, that's right.
Returning to the tipping point in sickle cell trait, I'd like to ask you a few more questions about that. You said that it varies from person to person. Is it a very individualised thing?
Yes, because everyone will have a different concentration of sickle in their blood. Same as with sickle cell disease, no 2 sicklers are the same. They have different tipping points for these things, but their threshold is much lower because they've got far more sickle hemoglobin going around. Yeah.
So could a set of circumstances, let's say running a marathon on a hot day, that might cause one person with sickle cell trait to reach tipping point simply not affect
Absolutely
another
right.
person
Absolutely right.
carrying the same trait?
Correct.
And in terms of the contributors to the mix that can lead to the tipping point, concentration, temperature, pH, and oxygen, can I ask you some questions about oxygen and hypoxia in particular? Is there any correlation between the degree of oxygen deficiency or hypoxia and the amount of sickling that you might see, or the rapidity with which a person will reach tipping
I'm
point?
really not the right person to ask
All
this.
right.
I'm sure there's some sickle biologists who could give you a really good answer, but all I can tell you is that the lower the oxygen, the more likely sickling will take place. And anticipating, and I'm sure what will come up later on, if you look at autopsy of people who have sickle cell trait, you will find generally a certain amount of sickle red cells in them. Now, that doesn't mean that they sickled in life, but of course after you die, the oxygen tension in autopsy blood in the body goes down, and the pH goes down as well, because that's what happens as part of decomposition. And that's why you see sickle cells in sickle cell trait, which is a clue that there's a sickle process. It doesn't obviously mean in most cases that it's anything to do with why they died. It happened after they died. And this is part of the great problem in interpreting autopsy pathology in terms of sickle cell trait, is how much happened before they died and how much happened after they died. And that's really the critical question in this case and in many of the other medical legal ones as well.
I'm sure, and it is a
We will
question
come
to
on to
which
that.
we will return. Let's go back to paragraph 4 of your statement, which is still on the screen. You mentioned having carried out 100 autopsies now on individuals with sickle cell disease.
It's more than 100. When I last did a count, actually, it's about 110. Yes.
All right.
But that's it. I won't do any more.
Can you explain what you would tend to see at autopsy if you carry out an autopsy on a person who has died from sickle cell? Well, perhaps I should let me reword that, please. Who has died as a result of the acute chest syndrome provoked by a sickle crisis? What would you expect to see at autopsy?
The acute chest syndrome, what you will see is in the lungs, in the circulation of the lungs, you will see a lot, most, all the red cells sickled. Now, you want to be very careful here because we're not talking about the big blood vessels like the main pulmonary artery that gets blocked off by thrombosis and deep vein thrombosis and embolism. We're talking about the smaller vessels, the arterioles, the capillaries, which is where gas exchange occurs, and the post-capillary venules, the very small vessels, the ones you can't see with the naked eye, but under the microscope you can see them very clearly. And if in those vessels, in what we would accept as an acute chest syndrome case, you find these small vessels are greatly dilated, so their diameter, their caliber is many times bigger than it should be, and all the red cells are sickled and are sort of matted together. That's what you see. And it's necessarily a subjective quantification, but that's what you see.
And during the person's life, when they go into crisis and start to develop this acute chest syndrome, what is the effect on their respiratory system of the red cells sickling and matting together? What impact does that have?
Well, subjectively, they become short of breath as the oxygen. The whole point of the lung circulation is you get oxygen from the air into the body, and this is going to be compromised when sickling of red cells starts in significant quantities. Obviously, there's a huge amount of sort of redundancy. You can sickle quite a bit and it won't matter, but they'll get to a point where it really does matter, and the oxygen, therefore, in the blood starts going down. This will simply make the sickling worse, and it becomes a sort of I've forgotten what the phrase is now, but it sort of gets out of control. So shortness of breath, fever, because the temperature goes up quite quickly as an automatic response. I'm trying to think, what are the other clinical syndromes? You see abnormal things on X-ray if you do one, or MRI scans. You can see basically the circulation looking a lot more solid. Well, it looks a bit more solid because it's filling up with more sickle red cells. And agitation, obviously, subjectively, it's not very nice. And patients who are sickle cell disease ones know very well when they're going into a chest crisis because they've done it before. And they say, oh, this is what's happening again, help. And the treatment, of course, is oxygen, hydration, blood transfusion, basic supportive care, and in nearly all cases they will be rescued, but not always.
Mm-hmm. And in those cases where rescue fails, what is the actual mechanism that brings about death?
Lack of oxygen via the lungs into the body, so you die, I was about to say of asphyxia. Let's leave asphyxia out. It's a rather different process. Ultimately, it's because the heart needs oxygen to keep beating, and the brain needs oxygen to keep you awake. And those two organs are the ones. I mean, if the kidneys or the liver fail, that doesn't matter. You don't die suddenly because of kidney or liver failure. You die because the lungs, the heart, and the brain don't work. And they don't work because the circulation taking oxygen to them is blocked.
Again, in paragraph 4, and we've spoken about this already, you've been involved in a number of medical legal cases, and 5, or in fact you think 8, previous deaths in custody or stress-related deaths amongst men with sickle cell trait.
And notice men, it's all men. I've not seen a woman have this, interestingly.
Can you explain that?
There are fewer women in the army. Exercise-wise, I don't suppose there's any difference at all. As to deaths in custody, I would be terribly simplistic and be shot down very rapidly, is that they don't get arrested as much as the men do, for lots of social reasons.
And in terms of sickle cell disease, is there an equal distribution of the disease between the
sickle
sexes?
Disease, men and women are the same.
Okay.
Yeah.
And
disease.
Insofar as you know, because I hear that a lot of people who have the trait won't know about it, but have you any reason to suppose that the trait is not equally distributed between men and women?
Oh, no, the trait is very well distributed. I mean, one interesting way you pick up people having sickle trait is that when the women deliver, and you are, for one reason or another, asked to look at the placenta, you can see the placenta is full of sickle red cells. You say, that's sickle trait. Well, you say, that's sickle. And you go to the Histopathology register and see where they are, and they say, no, this patient has sickle trait. Or maybe this patient has sickle disease, and we knew that anyway. Yeah. But if it's trait, it'll be often a new finding, which may or may not get disseminated to the patient or their healthcare workers. Who knows? I mean, we produce reports. We have no idea who reads them.
You've mentioned 5 or perhaps 8 cases, deaths in custody or relating to stress in men with sickle trait. And there's one that you discuss in some detail in your statement, and it's the case of Prince Fosu. So I don't think we need to go to the paragraphs in your statement, but could you tell us just a little bit about that case?
Okay. This is a young Nigerian man who was, I think, to be deported for immigration illegalities, whatever. And he didn't want to be deported. And so he indulged in the deportation centre in a dirty protest, rather like in Northern Ireland in the Troubled days. He took his clothes off. He didn't drink much, he didn't eat anything, he smeared feces all over the walls, and basically as a protest, said, I do not want to be here, I want to stay in England, please. And despite him obviously deteriorating, it would appear that not much was done to try and sort of bring him back. I don't know the great details, because I only got involved when it came to the inquest, because he died. And the pathologist who had done it was a forensic pathologist, because normally if there's a death in custody, you wouldn't get a non-forensic pathologist to do it, because the suspicion is that the authorities may have had a role in that person's death. So that's forensic, that's fine. And the forensic pathologist had said he died of, actually, it's in this account here, isn't it? Can I actually get the phraseology correct?
Absolutely. It's paragraphs 49 to
Thank you.
51, and perhaps we can just move to
Thank you,
those
thank
now
you.
on the screen as
Bum,
well.
Right, thank you. Paragraph 51. The original pathologist said he died of cardiorespiratory collapse associated with sickle cell trait. This is in the West London coronial jurisdiction, and the coroner at the time obviously was, well, I must backtrack. The inquest took place in 2020. The death happened 8 years earlier. There have been 8 years of legal arguments between the family, the police, the legal authorities, and so on. So finally, an inquest happened, and it was one of those inquest rooms where most of the people were lawyers, and a bit of family, and me, and the coroner. The original pathologist had said that this was cardiorespiratory collapse associated with sickle cell trait because he had seen in a couple of organs some sickle cells.
Sorry, can we just scroll down to 51, please, for the benefit
51.
of anybody who's
There we are.
following this? Thank you.
There was another pathologist, and the coroner then said, well, look, this doesn't look bad. And because of all the problems with the police, and particularly the prison authority, and whoever runs detention centres, and I'm not entirely clear who actually is in charge of these things, it was a sort of prima facie case where they weren't doing their job very well, otherwise he shouldn't have died. So he wanted support in, and I was asked, and also Rick James from Wales, from Cardiff, was also asked to look at the case. Rick, who's very good, said the cause of death was cardiovascular collapse, dehydration, malnutrition, hypothermia, and mania. Add that one in as well. Although he was a bit dodgy on the mania because pathologists aren't allowed to diagnose mania. We don't know what it looks like. And he put sickle trait under a contributor in part 2. You're well aware of how death certificates are organised. Part 1 is the main reason why they died, and part 2 will have factors, often several, which made them die of the main cause when they did, rather than last year or next year or something like that. In other words, it's a sort of contributor in terms of timing. I looked at it and I said, actually, I don't think sickle's relevant here at all. Why? Very simply, because there was no acute chest syndrome histopathology at all. The sickle red cells could be seen in the kidney, I think, or something like that, and that was irrelevant. If the sickle was going to be relevant to his cause of death, it would have to have blocked up the lungs a bit, and a lot. And for that reason, I said, I don't think sickle is relevant here, and the coroner believed me. And just to backtrack sort of 2 stages, is very interesting. The forensic pathologist, who I won't name, but is a highly experienced person, simply doesn't know and didn't know anything about sickle. And this is the main problem, actually, when these cases interact with death and authority. That the pathologists have no real experience because these deaths are uncommon and they don't know how to handle them.
And if we can just look at the very bottom of what we see on the screen, where you repeat your opinion was that sickle trait had not played any role in death.
Yeah.
Rather, it was cold, hunger, malnutrition, and neglect. And that's because in histology there were very few sickle cells.
Yeah.
He hadn't sickled enough, so it
Particularly
wasn't
in the lungs.
particularly in the lungs.
Yeah.
So it wasn't relevant to his death. The inquest jury concluded that the medical cause of Prince's death was a sudden death following hypothermia, dehydration, and malnourishment in a man with psychotic illness, contributed to by neglect and multiple serious failures.
That was a very fair and correct outcome. I just want to make one point about the word neglect, because it's a very, very difficult concept. And the advice that coroners give pathologists is never use the word neglect in your reports, because coroners have a different view as to what neglect is compared to the general population in which I count myself.
I see.
It's in other words, a very, very tricky area for obvious reasons.
I want to move on now to ask you questions about your involvement in Mr. Bayo's case.
Yes.
And just to be clear, you did not yourself carry out a post-mortem, nor were you present when Drs. Shearer and Bouhadir carried out the post-mortem on the 4th of May of 2015.
No, I was, in fact, this morning I was trying to remember why I got involved in this in the first place. And the answer is, I was approached by
Well, perhaps I can help you with that, and
Yes,
we
thank
can
you.
bring up an email that I think you received from the Crown Office on the 29th of May of 2018, which is COPFS 02468.
Les Brown, that was it.
Now, if we can scroll down to the substance of the email, please. So we can see 29th of May 2018 from Les Brown to yourself. There are some pleasantries. There's reference to the PERC investigators delivering histology slides to you on the 4th of June, and also 4 reports that will be sent to you for your consideration, although I don't think we see a reference to what the reports are in the body of the email. If we scroll down a little bit, we will see what you were asked to address. I would be grateful if you could address the following areas in your considerations, which may lead to the instruction of a formal report. So this wasn't a formal letter of instruction. It was the Crown approaching you to see if you could assist and suggesting that there might be an instruction further down the line. There are 4 bullet points. To comment on the supplementary report by Liz is it Swaya, and in particular her conclusions on the cause and mechanism of death and the significance of sickle cell carrier status. Whether the apparent sickling of cells occurred ante or post-mortem. From your own experience conducting autopsies in persons who are sickle cell carriers, the extent to which sickling of cells is noted generally, and whether it is possible or likely that sickle cell carrier status contributed to the cause and mechanism of death in this case, having regard to all of the relevant factors set out in the reports. Can we scroll down a little further just to be sure whether there's anything else? The email. So you received that email, and you would have received the histology slides on the 4th of June. What did the slides contain?
Right. Let's find the right bit.
I don't want to look at the slides at this point or your findings. I'm just interested to know, in general terms, what it was that you were being sent. What are histology slides? Help the members of the public who are perhaps listening to your evidence to understand what histology slides are.
Oh, sorry. Histology is the study of tissues down the microscope. It is a process that was invented in the middle of the 19th century in Berlin by Rudolf Virchow, whereby you take pieces of tissue, any tissue, and it is preserved, fixed, otherwise it'll disintegrate. It is processed so that you can cut very thin slices of it. And when I say thin, I mean slices of tissue that are 4 or 5 microns thick. A micron is 1,000th of a millimeter. So this is very thin stuff indeed. And it's chosen that because cells are of a certain size that if you look at tissues down the microscope, you can actually see them properly. So you have these 4 or 5 micron thick bit of tissue. They're put on a slide. You then add various vegetable dyes to it to highlight things, because if you just look down the microscope at tissue, you don't see anything at all. It needs to be brought out. And there's a standard combination of stains called hematoxylin and eosin, H and E. So in pathology terminants, we're talking about what do the H and E slide look like. H, hematoxylin, goes and highlights stuff that contains RNA and DNA, which is what the chromosomes are, so the nucleus is highlighted, and eosin sort of stains everything else, and that is red. And so what you're looking at in histology is sheets of cells stained red and blue, and you look at them and you learn simply by experience of what they're telling you. And in sickle, for example, you're looking at red cells. You can see the cells are red. We call them red actually because they're red when you stain them with eosin. That takes up the eosin. Red cells don't have a nucleus. That's been disposed of long before they get into the circulation. And you can look at this, how sick they look, whether they're sickled, whether they're normal shape and size, and so on. And so it's the interpretation of cells coloured down the microscope, taking from any organ. And this is the basis of all histopathology, pathology. It's the basis of all cancer diagnostics as well. You're not allowed to have cancer in most cases unless someone who's a pathologist says so, because they've looked down the microscope.
We heard evidence last week from Professor Fremont, an osteoarticular pathologist.
Indeed.
And he had looked at slides down the microscope, and he also told us about the H&E.
Oh yeah, good. So you've had
stains.
I hope I've said the same thing as he did. Yeah.
I think you did. But should we understand then that these are standard slides? The H&E is a standard slide that any histopathologist
Yeah,
would.
it's a universal process. The glass slides are 3 inches by 1 and about 1 millimetre thick, and this is the basis of all diagnostic histopathology globally, and has been really since the end of the 19th century.
Let's have a look at your reply to this email, and it's COPFS 03682. So we know that you received the histology slides on the 4th of June, and you responded to Les Brown on the same date. If we can scroll down a little to the substance of the email. Thank you. Here we are.
Yes.
Dear Les, seen the slides. I think that sickle trait did play a role in the death, along with all the other possibles: drugs, excited delirium, restraint, posture, etc. Not possible to quantify the contribution, of course.
Yep.
Do you want my short report with all the duty to the court material plus a mini CV, or will a straight letter to you do? And then if we scroll down a little more, please. I will not put this in my report, but from what I can see of the scenario, the police officers involved should not be prosecuted, assuming they approached and restrained Bayo, I think that should be Bayo, in the normal approved fashion appropriate for the perceived risk. There is a discussion to be had concerning whether a differential police approach is needed for subjects who are known to have a predilection, albeit uncommon, for sudden death under stress, even if they knew the facts in advance. An endless moral maze there. Sebastian, and I want to ask you a few questions about this, please. Can I take you at this juncture to paragraph 61 of your statement, and we'll look at that, and then I'll ask you some questions based on what's said on this email and what is said in your statement. So paragraph 61, you say, I've been referred to my emails of 4th June to Les Brown of the COPFS, where I write, I will not put this in my report. Do you know, if I was doing it again, I certainly wouldn't write that. What I can see of the scenario has obviously changed, because I think when I was sent all this original material, there was very little evidence or information or documentation about restraint. The death, in a sense, was slightly more spontaneous, but as I understand from what's happened in the last 7 years or so now, actually, a lot more information has come out about what actually happened. And I wouldn't write that now. At paragraph 62, I feel that this was an off-the-cuff comment at the time. Can you help us to understand the background and why you felt it appropriate to comment on the police not being prosecuted?
As I said, I wouldn't do that now. If I'd known all this was going to happen, I would have left that out. The background to this, just for the other people who haven't had the conversation that we've had before, is that I've changed my mind on this issue over the last 7 years as to how important sickle is. And I think at the moment it is less important than I thought it was in 2018.
Can I pause there? Sorry, I'm sorry to interrupt, but just to say that what I would like to do is explore the opinion that you gave in 2018.
Okay.
And then the opinion that you would give today, because
Yeah,
I
sure.
do understand that you have changed your opinion, and I'm keen to explore the reasons for that. If you could perhaps just bear that in mind, but I'm sorry I interrupted you. Please carry on.
No. So back in 2018, it really comes down, ultimately comes down to what the histopathology showed. So let me just quickly move to what I wrote then. So I know it's here somewhere. No, it's not that one. Must be this one. Right, okay. 84. And if you look at the second page, it is the histopathology review.
Sorry, would you like us to bring this up on the screen?
Yeah,
Would you
why
find
not?
that helpful?
Why not?
It's COPFS 84.
Yeah.
And sorry, if we can just orientate ourselves for a moment. So having had this exchange of emails with Les Brown, you were instructed to prepare a report stated June of 2018. This is your report, and if we can, we will go to the second page, but for completeness, if we can look at the first page, you repeat the questions that you were asked, which we've seen already in the email, and you go on to say the materials that you list the materials that you were provided with, and we'll perhaps come to look at that list again shortly. And you were keen that we look at page 2, Professor, is that right? Was it Histopathology Review?
Right. Yep.
Here we are, it's on page 2.
Right, well, bone marrow, no sickle cells. Brain, yes. Red neuron chain. This is essentially asphyxia-related brain damage from hypoxia ischemia. So there is some sickling. SRBC is the standard code for sickle red blood cells. Kidney. Massive accumulation of sickle cells in some of the vessels. No DIC, no cast. Liver, much sickling going on. Otherwise the liver was okay. Heart. Sickling, but otherwise it's okay. I should say the heart can carry on beating really almost to the bitter end. It's often the last thing that finally gives up. Thyroid, sickle, adrenal, sickle, lung. No, the crucial one is the lungs, actually. That's what it's really all about. Congested. There were 6 pieces. Now, the lungs have 5 lobes, 3 on the right and 2 on the left. So normally, when one looks at lungs, there should be 5 slides. I'm not quite sure where the 6th piece came from, so I'm not quite sure which bits are which lung. 6 pieces sample, alveolar edema, areas of sickling in veins and alveolar capillaries. And I emphasize it's the small vessels that have the problem, the big vessels don't. 3 out of the 6 have sickling, 3 out of 6 have mild or no sickling, and that's it. And at that time, and it has to be put in context of what else I was told, because just stand back, all these sorts of cases, you've got someone who's died, and you've got a putative risk for causing problem like sickle cell trait. And it's a question of balancing all these facts out. Let's not talk about him particularly, but if someone had an obvious massive drug overdose, then a bit of sickling on the side, you'd say, is irrelevant in comparison to that. If they'd had an obvious acute heart lesion, which was reasonable to cause death, sudden death, you wouldn't bring the sickle in. But the point is, when I was faced with this case back in 2018, all I had was a very brief story about being arrested and then sort of dying suddenly, and I didn't really get details about restraint. I had a drug toxicity report which didn't look particularly striking in terms of significant large amounts, although they may well be, and I'm not an expert toxicologist. And we had the sickling in the lungs, and I was thinking, could this possibly have contributed to why he died? Because I really don't see much else. So in a sense, it was, I won't say a diagnosis of exclusion, but it was a diagnosis of consideration of other factors. And I perhaps should have been more cautious and said, I haven't had all the facts in the case, but one might consider sickling to have some relevance. And to be quite honest, I think this report at that time, I overdid the importance of the sickling in terms of possibly causing lung damage, blocking up the circulation. Later, it became evident, and I think it was Nat Carey, who we will be talking to tomorrow, it said there was a hell of a lot more restraint than that. And I'm putting that phrase very loosely because that's my memory of it. And that's made me think, yeah, in this case, I think the sickling is now less important and other factors relating to how he was managed at the time of his arrest are more important. So it's a balance. And I do really want to emphasize there is no defined case definitional cut-off point as to how much sickling matters. It can't be done. It's simply too subjective. Liz Swire, and I was possibly slightly influenced by Liz, who certainly at that time I respected as a good histopathologist, was very emphatic that sickle did play a role. And I thought, maybe she's right. And so, in a sense, I slightly echoed that. Now, I wouldn't, because I think other factors are more important. But I do want to emphasize there is no agreed point to which you say that matters and that doesn't. It's that disease, it's not that disease. It's not like many other things where it's either there or it isn't, and we have agreed case definitions. This is a very subjective area, in part because it is multifactorial, it's cumulative, there can really be no strict case definition, but also because we just simply don't have enough experience. As I've said, I've seen 8 males who have died where sickle trait may or may not have been important in causing their death. And that's a career of over 40 years. No other pathologist has seen anything like that. And so no one really knows.
All right. We're going very shortly to consider the information that was made available to you by the Crown, and we're going to look at the opinion that you expressed in your initial report and what caused you to reach the conclusions that you did. I think we might be slightly at cross purposes, and the fault is absolutely mine. Can we please go back to the email that we were looking at a moment ago? That's COPFS 03682.
Okay.
So this precedes your report, and this is the email that you sent to Les Brown in the Crown Office on the 4th of June.
Yeah.
Bear with me. What I was hoping to draw your attention to, if we can scroll down a little, please, was the part at the top of the main paragraph there. I will not put this in my report, but from what I can see of the scenario, the police officers involved should not be prosecuted, assuming they approached and restrained Bayo in the normal approved fashion appropriate for the perceived risk.
Yeah.
And I simply wanted to hear from you why you felt it was appropriate for you as a histopathologist to comment on whether or not the police should be prosecuted. I wonder whether that was a matter that was in fact out with your expertise.
Well, as you can see, this is in a sense a private email. This is not a
Yes.
publishable report, although it is now public, and I make no apologies for that. But I have been involved in an awful lot, as a significant amount of this sort of approach, and the extent to which the officers of law and order look after people, because every coronial autopsy actually starts off, usually if it's death in the community, with the police being involved, because they go and see to make sure the person is dead. And so I'm well aware of what might happen. But as I say, for my recollections of the information I had back in 2018, the story was that he had been restrained under what, as I said, normal approved fashion and no more. That's what I understood at the time, and yet has suddenly died. To the surprise, I got the impression, of the police officers. So, if that's the case, I don't know whether to say this or not, but I'm not, actually I do say it, but a differential police approach and so on. I mean, this is a very difficult area, and it's really not for me to comment on. But it is very difficult when you've got someone who's behaving oddly and needs to be restrained. I assume the need is correct. And they did what they had, I assume, been trained to do, and yet, despite that, suddenly he was dead. That was the version I had at the time. I learned rather later it wasn't like that, and that's what made me change my mind.
All right. I'm conscious of the time, but before we perhaps break, as we usually do at about 11:30, can I just be clear that you made a number of assumptions around the need for a restraint and that officers had followed their training? You told us in the last few moments that you made certain assumptions. Is that fair?
The version, I don't know what I was sent. I'm not even sure I've kept it, and I certainly don't have it in front of me, but it would have been written information, Actually, it must have been
Well,
maybe
we'll-
derived from the original
We'll
PM
look
report.
at the report shortly because it sets your report sets out the information that was made available to you. But perhaps what it comes down to, Professor, is this: would you accept today? And I appreciate that this was a private email and not one that you ever expected to be before a public inquiry. But would you accept today that a comment on the police and their actions, their use of force, whether or not they should have been prosecuted, was not really one for you to make, that goes beyond the bounds of your expertise as a histopathologist and is ultimately a matter for the chair?
Yes. Full stop.
All right. Sorry, for the Crown. And indeed that prosecution is a matter not so much for the chair but for the Crown. But the facts of what happened are a matter for the chair, and any future prosecution would be a matter for the Crown.
Yeah.
Yep.
I had several conversations on the phone, I think, with Mr. Brown, and I have a vague feeling that this aspect may have come up, which might have been one of the reasons I put something in. But to say it's unforgivable, I don't know if it's the right word, but I wouldn't do that now. It's not right.
And do you understand that in giving evidence here today, you're here to assist the chair in understanding the significance of sickle cell trait in the death of Sheikh Bayo?
Absolutely.
And do you understand the importance of your evidence being independent and unbiased and objective?
Correct.
And do you understand the importance of staying within the boundaries of your expertise?
Correct.
So I wonder if this would be a convenient point to break.
We'll take a 20-minute break at this point. Ms. Thompson.
Thank you. Professor, I'd like to take you now to the report that you prepared for the Crown. You took us to it yourself a few moments before the break. If we could perhaps bring that up on the screen, COPFS 84. We looked at this very briefly to get our bearings. If we can scroll to the bottom of this page, we noted earlier that you repeat there the questions that were in the earlier email. And then beneath that, I have been presented with, and you list the documents that were made available to you to allow you to prepare your report. And they are the original autopsy report, a supplementary report from 2017 confirming that Mr. Bayo had sickle cell trait, Dr. Swayo's report and her supplementary report, and the histology slides. And if we can just scroll a little further, I think that's the end of the list of material made available to you. Just scroll onto the second page. Yes, it is. Did you feel that you had everything that you needed to express a view on the significance or otherwise of sickle cell trait?
Well, presumably I did at the time, but in retrospect, no.
And in retrospect, what additional information might you have found to be of benefit?
A more detailed account of what actually happened in the confrontation between Mr. Bayo and the police.
Now, you were not sent reports by other forensic pathologists.
Not at the time, I don't think.
No.
Otherwise, I would have listed them.
Yes.
Yeah.
Well, at that point in time, a report had already been prepared by Dr. Carey, whom you've mentioned, by a Professor Jack Crane, and several reports had been prepared by a Dr. Lawler. All forensic pathologists, and all of their reports predated the instruction of yours. Were you aware that other pathologists had been instructed to prepare reports?
No.
Would you have expected to have had sight of them?
I can't remember. This is 5 years ago. But in
Sorry,
principle, yes.
In principle, in a general sense.
Well, in a general sense, because this is a death in custody, yes, there will be others, because Liz Swire is not a forensic pathologist.
Yes.
So I'd expected others, but I wasn't shown them until after I wrote this.
All right. You say you weren't shown them until after you wrote this. Have you seen them subsequently?
I think I've seen Nat Carey's, but actually I spoke to him, because we met, and he said, he knew what I'd written, and he said it's not so simple. There was an awful lot of restraint processes and so on going on, and then I probably have seen his report since then. At least I know I've seen his conclusions, because Miss Wade presented them to me, I think. No.
So you were shown some material by the inquiry as part of the process of taking your
Yeah,
statement?
this is much more recently, the last year, within the last year, not in 2018.
So the reports that were not available to you at the time that you prepared your report were not subsequently sent to you by the Crown for comment?
Does it say so in my final statement? Because I don't want to contradict myself.
No, I don't believe it does. I think the only reference in your statement is at paragraph 8.
Yeah.
If we could quickly pull up paragraph 8, I'd be grateful. I've been asked whether there would be any other material that I would have expected to see in the instruction from Crown Office. No, in the circumstances of the death, the autopsy report, versions of it, someone else's opinion, and I was sent the histology slides also. I must have sent them back a long time ago. I've been asked if there were reports by forensic pathologists in a case like this. Would I expect to see such reports? Yes, I would. I think that's the only comment on what you had seen.
Well, hang on, just a moment. I actually brought with me all the paperwork I have in relationship to this case. So I can tell you exactly what I have.
And is that what you have in front of you now?
That's what I brought out of my briefcase. Yes.
I see. Well, in that case, I wonder whether we can simply park this issue for now and revisit it, and you can look at through your own file at your leisure over an appropriate break.
Okay.
Thank you. But certainly, so far as your report is concerned, you state in your report, if we can return to the report, please, at the bottom of the first page, that you were provided with the autopsy report, a
yeah.
supplementary report,
Yeah.
and two reports by Dr. Swaya.
Swaya.
Swaya, thank you.
Sorry, and her supplementary. And this is correct, because I always put in all the documents I have seen when I'm making a report. So the omission means that I didn't have them.
You didn't have them. And just as a cross-check on that, if we might return very briefly to the email that you were sent by Les Brown at COPFS 02468. And we see, he says in the middle of the first paragraph, I will forward a total of 4 reports for your consideration in relation to this case separately. Do you see that, Professor?
Yeah, I do see that, but I'm not sure if I got them.
Well, there are 4 reports listed in your report. The two,
I see,
the two
those 4.
post-mortem
Yes.
reports,
Sorry,
and the 2 reports by Dr.
That's
Swaya.
right. There's 2 from the original pathologist and 2 from Liz Swaya.
Yes.
Correct. That's the 4. Yeah.
So Les Brown refers to sending you 4 reports. He says he will send you 4 reports, and you have narrated in your report the receipts of 4 reports, 2 post-mortem reports and 2 by Dr. Swaya.
Yeah.
Would it have been of benefit to you to have seen the other pathologists' reports?
Yes.
What would the benefit have been to you?
More detail about the confrontation between the decedent and the police.
And from a medical perspective, would there have been a benefit to you in reading
It
the
does.
pathologists' reports?
It would indeed, because as I said earlier before the break, the definition of whether sickle plays a role in this sort of death is subjective. There's no defined hard point. And the more information you have about other alternative explanations for causing a death, then the less important the sickle will be. It's really as simple as that, actually. It's a balance.
And you weren't sent statements by the Crown Office, statements of the police officers involved in the restraint or civilian witnesses?
Well, I don't normally get sent that sort of stuff, but it might have been helpful in this case, and if I'd had more information available, I would presumably have written my report differently back in 2018. Correct. It's certainly the sort of information that comes out in inquests, where you realise that the whole thing was actually rather different from what you were told when you did the autopsy, and you change your mind. And in coronial inquest courts, that's perfectly satisfactory. When different information arises, you alter your perspective.
And do you feel to any extent at a disadvantage not having had sight of the other pathologists' reports or statements or a summary of the events that transpired at Hayfield Road?
So, sorry, I didn't quite get what the question was. I got lost
Sorry.
in that.
To what extent, if at all, do you feel put at a disadvantage by not having
Well, I do
had
in retrospect, but at the time,
reports?
obviously, I didn't feel disadvantaged.
Let's return to your report, please. And if we can look at the second page at the histopathological review.
Yeah.
And you took us through this very quickly before the break. And I wonder if we can simply look at the significance of your findings in turn. So the bone marrow, no sickle cells. Is that a matter of any significance from your perspective?
It's a piece of information. It's a datum. Mm-hmm.
Does that information tell you anything, the absence of sickling in the bone marrow?
In people with, even with people with sickle cell disease, if they die suddenly, they do not necessarily show sickle cells in their bone marrow, but they might. And similarly with sickle trait. That's not the critical point. It's variable. The whole business about what happens to sickle red cells that contain the sickle gene and abnormal hemoglobin after death is fraught, as I'm sure you're going to bring up in more detail. And you will have seen many accounts from people who say you can place no trust whatsoever in whether you see sickle cells or not. It doesn't mean anything because they're sickled after death. To an extent that is true. I'm talking from my personal experience, but I do believe that when particularly the the lung vessels are extremely abnormally distended with sickle red cells, then you can take that as being meaningful, because they wouldn't be so distended at the time of death if that process hadn't happened before death. I explained earlier what the acute chest syndrome pathology is. It's distension, widening, dilatation of these blood vessels with large numbers of sickle red cells. And I do not believe that that process happens in normal sickle trait people, not under stress or anything else, as a post-mortem event. I believe it is pre-mortem pathology, and I will stick with that. But it is an opinion. You know, as I say, there's no hard and fast rules, and you will find other pathologists who might say different.
Before we discuss the lung findings in more detail, can we perhaps look at the other slides that you considered?
Yep.
We've spoken about the bone marrow.
Yep.
The next is the brain. Early red neuron change only from hypoxia ischemia. Some vessels have sickled red blood cells. What does that tell you?
Well, it means that he's died because his brain neurons have suffered from lack of oxygen, lack of blood, and he's brain dead, or is becoming brain dead.
Kidney, very congested, some parts just normal red blood cells, but much massive SRBC accumulations in arteries, capillaries and veins. No disseminated intravascular coagulation, no casts and tubules. What does this tell you?
Right. This is most of my kidney histopathology reports read a bit like that, because these are things that you look for. DIC means that there's no blood clots, there's no thrombosis going on inside the glomeruli, which you can see under certain circumstances in sickle. The casts means that there is no muscle necrosis that has gone on for long enough for muscle protein to come out into the blood, go to the kidneys and deposit in the tubules, and we call them myoglobin being the muscle protein casts. That's very commonly seen in people who have crush injury of muscle, like someone who's been lying on a concrete floor. Get crush injury of the buttock muscles and the thigh muscles, and that injured muscle ends up in the kidney. You can see it. So I just simply put that in as a relevant negative. I believe in stuffing my histology reports with lots of significant negatives, because they answer questions.
And should we understand from what you've just said that when you were looking at the histology slides and commenting on them, you're not limiting your analysis to the presence or absence of sickling, you're looking at the tissue more widely?
But particularly I'm putting other things that I've seen in the context of sickle in general deaths, just to say that these are there and these are not there. Also, to be quite honest, to make it look more detailed than the original pathologist, to show that I know more than they do.
And returning to the kidney, where you say much massive sickled red blood cells, accumulations in arteries, capillaries and veins, what does that tell you?
It means that around the time of death he sickled a lot in the kidneys. The obvious question is how much happened before death and how much happened after. Can you tell? No.
When you say much massive SRBC, is that technical language? What is massive?
No, it's just subjective. It means lots.
Lots. Moving on to the liver, severe congestion of vessels and sinusoids, much SRBC present, architecture normal, no steatosis, no necrosis.
Fatty change indicating recent alcohol or other drugs. No necrosis, bile ducts normal. Yeah.
And in relation to sickling, again, you've recorded much SRBC
There's
present.
lots, yes, that's right. I don't think I photographed this case, which perhaps I should have done, but it might have been helpful actually. So I can only go from the words. I haven't reviewed the slides since 2018.
I see.
I don't know if they're still available.
Moving on to the heart, you observe the right ventricle is normal, left ventricle normal, apart from acute contraction bands scattered, which you say are from resuscitation.
Yes.
No scars, no acute ischemia or myocarditis, much SRBC in vessels and capillaries. So again, we've got more sickling in the heart.
And that's another variable thing. Some sickle trait and sickle disease people have lots in the muscles when you see them when they're dead, and some don't. It's variable. And again, it's not a critical thing, because sickle trait or disease does not damage the heart acutely. So it doesn't really matter what's there.
If we can scroll down a little, please. After the heart is thyroid, normal apart from much SRBC, and you say the same in relation to the adrenal. Is that the adrenal glands? What conclusions, again, do you draw from that? Simply that sickling is present?
It just means that all through the body is sickling.
Okay. Okay.
And these are the organs that were sampled, so they have a separate paragraph. One doesn't normally necessarily take samples of thyroid or adrenal if to the naked eye they look perfectly normal, but they were there, so you comment on them.
And finally, the lungs, congested and distended vessels, 6 pieces sampled. You explained earlier that ordinarily it would be 5. Areas of alveolar edema and no associated sickling, areas of sickling in veins and alveolar capillaries. 3 out of 6 pieces have this sickling. 3 out of 6 have mild or no SRBC in the non-edema areas. No thrombi, no alveolar hemorrhage. Can you help us to understand the import of your findings in relation to the lungs?
Well, it's a description. It's a semi-quantitative description of how much sickling is going on in the relevant areas of the veins and the alveolar capillaries. And half the samples taken did have it, and the other half didn't.
What does that tell you?
Well, this is the problem, actually. And I remember thinking about this at the time, thinking, well, we don't have another good reason, really, as to why this person has died the way he did. Remember, I didn't have the complete story. So I thought in that context, and also possibly biased a little bit by Liz Swire's previous report, who emphasised that a lot, I thought perhaps the sickling did have a role here.
Can we turn to your statement for a moment, please, and look at what you say there about your findings in relation to the lungs? Paragraph 15 through to 18. 15, this is in relation to the lung. You say this is the crucial one in people who have died under restraint and exertion, and you can say that sickle really is very important here. Why is the lung the crucial sample?
Sorry, I didn't get the question. Try again.
Here, if we scroll up just a little bit, we'll see that we're talking about the lung tissue.
Yeah.
And then at paragraph 15, you say this is the crucial one.
Yes,
in people
that's
who
right.
have died under restraint.
Well, I've explained that several times already, because
well, do indulge me. Why is it that the lung tissue is the crucial sample?
because from my experience and from the literature of people who have died under restraint and or exertion, and there's no other obvious cause of death. It's because the sickling in the lungs is why they're dead.
Right. Okay. Sorry, did you want to add to
No,
that?
not particularly.
Paragraph 16.
Yep.
Now, in this particular case, you will notice I've been quite precise that whoever did the autopsy took 6 samples of lung, I assume from 6 different parts of the lung. The lung has 5 lobes, so probably it's 1 piece from each lobe plus 1 extra, but I don't think it was stated exactly where they come from. Some bits don't have any sickling and some bits do, which is why it's not quite so clear-cut as some of the other more obvious ones, where all the lungs are very sickled. And you can say this is a classic example of the scenario called the acute chest syndrome, and this is well known in sickle disease.
The word "this" here applies to a classic one where it's all sickled,
Right.
not this as in this particular case.
I see. So with acute chest syndrome, you would expect sickling throughout the lung.
Yes.
Okay. Whereas here, you have found sickling in
Partial.
3 out of the 6 samples taken.
Exactly.
Can we look at the following paragraph, please, again in relation to the chest? It obviously happens much more commonly in people with sickle disease, and what it means is that in the lung blood vessels, the cells sickle, and they simply can't move. If you can't have blood moving through the lung stops, the heart stops, and you die. It's called a crisis due to acute chest syndrome. Mr. Bayo has some aspects of the acute chest syndrome, which is why I think sickle contributed. Having thought this through, I would now say my bottom line is that I think we should probably move sickle trait down in the cause of death list from being in part 1 into part 2 as a contributor, but not the main cause. So we'll come in the fullness of your evidence to look at the change in your opinion, but focusing on the first part of that paragraph, you say that Mr. Bayo has some aspects of the acute chest syndrome, which is why you think sickle contributed, and I take that to mean contributed to death. What are the aspects of acute chest syndrome? Is it simply the presence of sickling in the lungs?
Yes, that's the pathology.
That's the pathology.
Yeah.
I see. Let's return to your report, please. And if we can move on to the second page. We've looked at all of the individual tissue samples and what you found on examination. If we can now go to the commentary. You say you do not need to repeat the chronology of the circumstances of the death of this man who had sickle cell trait, and then in brackets HbAs. What's HbAs?
HbAs, hemoglobin AS. I mean, it means you've got half of the hemoglobin in the cells is normal A, and half of it is sickle. HbAs is this sort of code for sickle trait status.
I see. You continue, from my review of the gross and histology features of the deceased's tissues, and based on my previous experience of such deaths in HbAs, and knowing the literature as it has been presented by Dr. Swire, I believe that HbAs trait did contribute to the death of Mr. Bayo. When you say that you reviewed the gross and histological features, what do you mean by the gross features?
The gross features actually really means there's no other cause of death evident. That it wasn't a straightforward heart attack, stroke, pulmonary thromboembolism, etc. That's what I meant by that. There was no gross other pathology. All the pathology here is subtle histopathologic.
I see. Yeah. And when you refer to the histology features, are those the features that we've been discussing under the section headed
that's right.
Histological Review? You make reference there to drawing on your previous experience. To what extent did you require to rely on previous experience, and how did that inform your analysis?
Totally. From looking at the cases as in that table, which no doubt you'll come to anyway, of the 8 cases, this being number 5, I think, on that table. And as it comes down to quantitation, ultimately comes down to the balance of quantitation of how much sickling is going on the lungs, consistent with classic cases of acute chest syndrome where there is no argument at all, versus alternative possible explanations for the death. And the fewer there are on the alternative explanations, like obvious gross pathology, then the more emphasis you're probably going to put on the sickling there in the lungs. But on the other hand, if it turns out that the other features in the case, of which one was not so much aware at the time, are actually rather more emphatic than you believed, then in a sense you downplay the sickling. To put it fairly crudely, but that's what it's about.
You mentioned literature. You say knowing the literature as it has been presented by Dr. Swire.
Yeah.
Did you refer to literature to inform your decision making?
I looked through her literature list and I said, yeah, I've read that, I've seen that, I've got the book and so on. I didn't go into any more details.
I see. And was it literature that was familiar to you?
Oh, yes.
Returning to your conclusions or your commentary section, you say, there is no doubt that HbAs persons have died in custody or under stress, in brackets, heat, dehydration, exercise, where the main pathogenesis is a sickle crisis affecting the lungs particularly, the kidneys, skeletal muscle and the heart, and this has led to death. There is no doubt that the vast majority of persons with HbAs who undergo life's daily stresses do not suffer any such syndrome. The critical aspects are therefore the level of stress and accompanying elements such as dehydration, drugs, alcohol intake, muscle activity, and body temperature. I'd like to ask you some questions about that paragraph. You refer to HBAS persons dying in custody or under stress, and we've discussed already the military paper and the papers relating to sports people. When you refer to stress there, you put in parenthesis heat, dehydration, exercise. Are these key stressors? Are there any other stressors that could potentially be relevant?
Those are the main ones. We went through it before, didn't we? Hydration status, concentration of sickle in the red cells, which of course is inbuilt, oxygenation and acidity, which relates to muscle activity. Drugs and alcohol, of course, relate in a sense to the other side of the scale, as are they sufficiently bad, abnormal, to have caused death in their own right.
Okay. And at the bottom of that paragraph, the one that's now at the top of the screen, you refer to the critical aspects being the level of stress and accompanying elements being accompanying elements such as dehydration, drugs, alcohol intake, muscle activity, and body temperature. For your information, Mr. Bayo's blood and urine were subjected to a screen and were negative for alcohol.
Yes.
Does that change anything? Is that particularly relevant here?
Well, alcohol is not relevant.
So alcohol
Yeah.
is not relevant,
Yeah.
all right. But would that have an impact on any of the conclusions that you
No,
reached back
not really.
in 2018?
No.
Okay. And so far as temperature is concerned, we heard evidence that in hospital, Mr. Bayo's temperature was recorded at 35.8 degrees.
35.
35.8.
That's low.
But that it was a cold, wet morning and he was outdoors only wearing a T-shirt.
Yeah.
Do either of those pieces of information
How was
change
the body?
anything?
It gets very how was the body temperature actually measured? Because you can get any number you want depending on where you put the thermometer or the device. I don't know, and I don't know if I did know either.
All right. But otherwise, in that paragraph, if we can scroll up so we can see the full paragraph again, please. You make clear that some HBAS persons have died in custody or under stress as a result of the sickle crisis, that you've explained to us in detail in your evidence, but you also observe, and again you've told us about this today, that the vast majority of people with sickle cell trait who undergo life's daily stresses do not suffer any such syndrome.
Yeah.
Continuing to the next paragraph of your report, please. You say, in evaluating the clinical pathology, the critical aspects are the amount of sickling of red cells and in how many critical organs. There is no rigid morphological case definition, we must acknowledge, that separates harmless sickling from harmful sickling. It is inevitably somewhat subjective and informed by the observer's previous experience, and it must be acknowledged that changes in the body's tissue post-mortem can contribute to sickling of red cells. But the quantity of sickling here tells me that this is much more than just post-mortem sickling. It happened peri-mortem as part of the death process. So I'd like to ask you some questions around that. You say that...
I stick with that paragraph.
All right.
Yeah.
That's helpful to know. You say that the critical aspects are the amount of sickling.
Yeah.
Can you comment on the significance of the amount of sickling in Mr. Bayo's case?
Well, we've already been through this. I put massive in the kidney. I can't remember quite what it did look like, but it's obviously far more than any sickle trait person who died, more in Mr. Bayo's kidney than in a comparable sickle trait kidney from someone else. Must have been more, otherwise I wouldn't have written that.
And so far as the number of critical organs are concerned,
Yeah.
It appeared that with the exception of the bone marrow, you found sickling.
It's everywhere, isn't
everywhere.
it? Absolutely, yeah.
Okay.
And that's certainly what impressed Dr. Swire as well, that it was everywhere. But she won't have seen as much sickle pathology as I have, but that impressed her, yeah.
So what conclusions would you draw from both the amount of sickling present and the number of organs affected?
Well, as I said, it's a little line, arrow moving along the scale, and the more you see, the more you think, sickling might be relevant here. And when it comes to the crucial one is the lung, how much is going on in the lung, as I've said several times before. Because if something's going to stop the body function such that the person dies, it's going to be in the lung. That's the critical bit that's affected. Because as I've said already, you can damage the kidney, you can damage the liver and so on, but that's not going to kill you, not acutely anyway.
And you've explained to us already that of the 6 lung samples, there was sickling present in.
Yeah, I know, only in 3, yes. Perhaps I should have hedged a bit more, but for some reason or other, back in 2018, I didn't.
Returning to that paragraph, you say there's no rigid morphological
Yeah.
case definition that separates harmless sickling from harmful sickling.
Yep.
So some sickling can be harmless then?
Well, some of it can happen simply after death, and it's nothing to do with anything. It's part of the decomposition process.
Okay.
That's what I meant by that, actually.
I see,
Yeah.
I see. So it's not that we're talking about sickling in lifetime that hasn't taken a person suffering from sickle cell trait to tipping point.
It could include that, but the point is it's very difficult at autopsy work to know which one is which.
Yes, and you go on to say that the quantity of sickling here tells you that this is much more than just post-mortem sickling.
Yeah, that's what I thought at the time.
And is that drawing on your experience?
Absolutely, because there's nothing else to draw on. And some of the papers produce pictures and so on, but they're not much help. In the end, it's what you've seen before and how you've interpreted and how, in a way, those deaths have been, if they've been reevaluated and tested again, and what the final conclusions were. I mean, in a sense, in this particular case, it's another example of learning,
Yes.
that you readjust where your needle is on the dial according to what you have seen and what you have learned subsequently. That's how we all work.
Can we move to your statement briefly, please? Because there are a couple of paragraphs there in which you deal with the difficulty in determining whether sickling is ante-mortem or post-mortem. Can we look, please, at paragraphs 30 and 31? I'm asked how I can tell that sickling happens prior to death and contributes to death as opposed to it was sickling that occurred around the time of death as part of the process of dying. When people who have sickle traits who've died of something else die, you can get after-death sickling that occurs because the body cools down and it becomes slightly acid, and that can turn red cells sitting harmlessly in blood vessels into sickle cells, and we can see that. There's a difference, actually. The sickle happening before as opposed to after death. This is partly based on the organ distribution of the sickling and quantification of the process, which is a subjective histopathological evaluation. So again, you're drawing on your experience in making this assessment.
Everything there is true. Yes.
And if we can move to paragraph 31. Almost certainly in Mr. Bayo, like in all the other cases, there's an element of both because you don't autopsy people in the moment they die, or very rarely. So there's always going to be a little of additional post-mortem sickle trait. It happens anyway, sickling, you've called it. I was making a comparison between the average sickle trait person who's died in this kind of case, like Mr. Bayo's, where there's more sickling, and it struck me it probably could have contributed to death. In other words, it happened in the time leading up to the point when his heart stopped. However, to emphasise again in terms of importance and significance of the sickle cell trait, it's a lot less than the recreational drugs and the struggling and the restraint. Those are the important things here. Can we return to your report, please? And you say that the quantity of sickling in Mr. Bayo's case, sorry, this is on page 3. You say that the quantity of sickling here tells you that this is much more than just post-mortem sickling. Can you help us to understand your thought processes when you reached the conclusion that what you saw histologically was more than post-mortem sickling?
Yes, that's right. And I still think that's correct in this case. But it's balanced against other factors which have become more evident since I wrote that.
Okay. But what led you to the conclusion that it was more than just post-mortem sickling?
Oh, because the lung vessels where they were affected were very dilate. They were very distended. That was the crucial thing.
And you said earlier in your evidence that's something that happens in life and not after
I thought
death.
that happened in life because it's not what one sees in people with sickle trait who have died of other reasons.
I see. You say it happens peri-mortem as part of the death process. That's at the very
Yeah.
end of that paragraph. What do you mean by perimortem here?
In the period just before, during, and after death.
Okay, so that's different from antemortem.
Oh, it will include a bit of antemortem, but it's leading to death,
I
leading
see.
towards death.
So perimortem is around the time of death,
Yes,
is
around.
that right?
Yes, that's right. Like peripartum is around the time of delivery, not necessarily at the moment when the baby comes out.
So can I just ask you to clarify, please, in your opinion, when did the sickling that you saw in Mr. Bayo's case take place? If perimortem encompasses before, during and after death, to what extent was the sickling that you saw, in your opinion, antemortem?
I thought it was antemortem because the lung vessels were particularly dilated, and that doesn't happen, as I've said several times, in someone who's got sickle trait and just dies for some other reason. You don't quite see, you don't see the lungs look different.
So although your report says that the sickling happened perimortem as part of the death processes, we should understand that there was evidence to you as a histopathologist that at least some of this sickling was antemortem.
Yeah, that's what I inferred from the tissues. Yeah.
Let's move on to the next paragraph of your report, please. In the Bayo case, I'm impressed by the quantity of sickling in the organs, such as the heart, kidneys, liver, thyroid, and adrenal, much more than I expect to see in the organs of those with HPAS who died of unrelated causes. The lung tissues show more variable amounts of sickling, but where it is present, it is again more pronounced, i.e. the blood vessels are more distended. You've told us about that already, than one would normally see in HPAS persons dying of other causes.
I stand by every phrase there.
Moving through your report, please, to the next paragraph. Dr. Swaya presents a good diagram of the potential clinical pathology of death in this case, with which I do not significantly disagree, apart from suggesting a more prominent component from the lung pathology. She concludes with the cause of death as 1A, sudden cardiac death, 1B, sickle cell trait, recreational drug use, struggle against restraint. I would suggest an alternative, 1A, sudden cardiopulmonary failure, 1B, sickle cell trait, recreational drug use, struggle against restraint. The last feature, struggle against restraint, can include positional asphyxia, but as a non-forensic pathologist, I do not wish to be drawn into more detailed discussion in that area. Scrolling down, please. Importantly, I do not think we can quantify the contribution of the three factors presented in 1B and state with rigour that one is more or less important than the others. It's multifactorial. Now, I appreciate that this was the opinion that you expressed in 2018 and understand that your opinion has perhaps moved away to an extent. Yeah. But if we can stay with the text of your report for now, can you help us to understand the difference between 1A and 1B in the cause of death?
So, what's the question again?
The difference between 1A and 1B on a death certificate in general, not with reference to this case.
The bottom line of any cause of death sequence, which here happens to be 1B, it could be 1C, it could be 1A, is the pathology, the clinical pathology, what goes into the national statistics. 1A, if there is one, is the mode by which that pathology caused the end of the life of that person. And often one leaves it out. In fact, statisticians don't like that because it gets in the way. They just want the bottom line. And I just refined the bottom line because it made it seem as though the sickle cell trait had stopped the heart. It hadn't. The sickle cell trait had blocked off the lungs, or contributed to blocking off the lungs, stopping the circulation, and as an end result, stopped the heart. It's just being picky and nerdy about the precise pathology going on.
We've heard that death certificates also have a part 2.
Well, I don't think the original version had a part 2. I mean, no one was put in.
Sorry, death certificates in general. Let's move away from Mr. Bayo's case.
Well, they had the option to fill in part 2. One doesn't necessarily use it.
And what would one use part 2 for?
What you put in part 2 is other conditions, acute or chronic, that contributed to the death, not so much in actually causing the death, but in influencing when it happened and how it happened. I can tell you that every certifier of death certificates, every pathologist, every coroner, and remember coroners write death certificates on advice, has a different view of what goes into parts 1 and part 2. There is no consistency, just as there is actually, and it's a separate debate, no consistency in what is a natural or an unnatural cause of death. This is simply an inevitable conflict between medicine and law, where there's no general agreement on details as to what should go where.
So back in 2018, the only difference between yourself and Dr. Swire was that you would have preferred sudden cardiopulmonary failure over sudden cardiac death. For members of the public who are perhaps listening to your evidence, can you explain, please, the difference between sudden cardiac death and sudden cardiopulmonary failure?
Well, the cardiopulmonary failure here means the acute chest syndrome. That's what it's shorthand for that.
Now, in the paragraph beneath the cause of death, you say the last feature, struggle against restraint, can include positional asphyxia. As a non-forensic pathologist, I do not wish to be drawn into a more detailed discussion in that area. What did you mean by that? Why did you not wish to be drawn?
Well, what I was really meaning is that I wasn't told very much about what actually happened in the struggle against restraint. And I had the impression from the original autopsy report that that aspect was not particularly important. Positional asphyxia is, can I ask you, have you had forensic pathologists talking about positional asphyxia in this inquiry up to this moment?
Yes, we've heard evidence from the doctor who performed the autopsy, and we will be hearing evidence from another forensic pathologist in the fullness of time.
Good. Well, the practical point is, as a non-forensic pathologist, I don't have much street cred in going in for positional asphyxia if there is third-party involvement. I just put it as crudely as that. I've seen deaths from positional asphyxia where people have, because they've been drunk, flopped over a sofa and basically their head and neck is resting on the arm of a sofa and they have asphyxiated because they were drunk. Were that to be in relation to a possible criminal offence and third-party involvement, I don't get involved because that's forensic stuff. And I'm simply being cautious there, perhaps unnecessarily so, that I don't have it, and because the death occurred in confrontation with the forces of law and order, I couldn't really make any comment because I didn't know enough, and I don't have any street cred as a forensic pathologist.
Thank you. I want to move on now to ask you questions about the extent to which you perhaps departed from the opinion that you expressed in 2018 and the reasons for that departure. And a good place to start might be by going back to your statement, where you give an explanation at paragraph 25. Reflection on my report 4 years on, I don't think sickle cell trait is quite as important as I thought it was perhaps back in 2018. That's partly influenced by lots of discussions I had with coroners in England about how we should be phrasing causes of death, what is important and what is less important, what goes into part 1, which is the main thing, and what goes into part 2 as a contributor. If I was doing this case again now, I would move the reference to sickle cell trait to part 2 of the death certificate. I would not frame the entire story of his death around sickle cell trait. I would just simply put that in on the end as a small extra factor. As explained earlier, that it may well have shortened his life expectancy by a couple of minutes, given the stresses he was under at the time.
The only thing I would change is, I don't quite know why I think I was slightly pressed by Miss Wade about time, and I said, well, maybe a couple of minutes or something like that, but it's not something I want to be taken precisely. But the rest of it's true. And particularly, I remember now, back in those times, that the coroner for Southwark was pressing me very hard to join him as a co-author in 2 big papers on what is a natural and unnatural cause of death. And the point is, we couldn't agree, which is why I took my name off it, and it got published by other means. It's actually a very complicated issue.
I think in fairness, when you say at the very end of paragraph 25, a couple of minutes, you go on in paragraph 26 to say again, that's guesswork. I can't quantify
Thank you.
that.
Yes, absolutely
Seriously, no one can do that. Continuing to read through paragraph 26, please. On many occasions I've provided opinions that sickling played no role whatsoever, but conversely I have seen ones where it absolutely definitely did, and if they hadn't had sickle, they probably wouldn't have died when they did. I don't think this case, and that's Bayo's case,
Yes.
comes into that category.
Yes.
Can you help us to understand then why it is that you feel now in 2023 that sickle cell trait perhaps played a less important or less significant role
Okay.
than you had thought in 2018?
Two reasons, or two related reasons. One, I was informally given summaries and some evidence that a lot more restraint than I had appreciated back in 2018 had occurred in this case. Also, and this will be a fairly obvious bit of information to everyone in this courtroom, there's been a huge amount of public information about police restraint and death, particularly, but not only, in black people. And the George Floyd case is the calling one in where this poor man in Minnesota certainly did not have sickle trait. As far as I know, he didn't anyway. But he was photographed doing what I can't say this really. I can say, well, one would not like the police to be doing things like that. The point is that everyone saw that restraint kills. Restraint, pure and simple, prolonged, kills. And it was that sort of thing in mind when I heard that in this particular case, back Mr. Bayo, that there was more restraint and struggle going on than I had appreciated back in 2018. I thought that actually I'm going to change my mind and downgrade the role of sickle played in his death. It's as simple as that.
Can we look at paragraph 35 of your statement, please, where you explain a little bit more about your change of opinion? You say, I think I would modify that statement now. Sorry, for context, we should look at what came above that. It's simply a quote from the final paragraph of the commentary section of your report with the cause of death, your preferred cause of death back in 2018. Paragraph 35, you say, I think I would modify that statement now and make it a little less generous. Since I produced my report in 2018, I have been given much more information regarding the circumstances of Mr. Bayo's death, information, i.e. more about the degree of restraint and more forensic opinion. And at paragraph 36, you go on to explain the difference that this additional information has made to your thinking. You say, I would actually now put recreational drug abuse, struggle against restraint. I'm not going to sort out which of those two is more important, but definitely sickle trait in a different line, as it is a less important phenomenon.
Different line being part 2, not part 1.
I was about to ask, and I think you'd explained elsewhere in your statement that it would go under part 2 of the death certificate, part 1. And for your information, when Dr. Shearer gave her evidence, she was taken to a relevant part within your statement where you said that you would include sickle cell within part 2 of the death certificate today, and asked to comment. And said, yes, that's very sensible. That's I would agree with that completely. Yes, was what she said. So it would appear that you're on the same page in terms of the role played by sickle cell trait and the status it should be afforded on the death certificate. Can we look at paragraph 37? I'm asked whether, but for sickle cell trait, Bayo would have died. Yes. Now, I say that as a non-forensic pathologist. Just from what I've learned over 45 years of looking at dead people, and quite a lot of time looking at sickle patients particularly, it seems to be a very minor component here. And at 38...
That's a comparative statement compared to other events.
Compared to other events,
yes.
I see. The other events that you know about now, meaning the restraint and the events surrounding that? Sorry, Professor, by comparative, what other events are you comparing?
More information about the degree of restraint applied.
I see.
And again, in the context of much public knowledge recently from America about restraint-related deaths in custody.
And at paragraph 38, I'm asked whether, in my view, sickle cell trait made a material contribution to Shekel Bayo's death. Yes, but a small amount.
Yeah.
And I wonder if I can just ask you about the language used here. In paragraph 37, you say a very minor component. In paragraph 38, you say a material contribution, but a small amount.
Sure, but as you know very well, these are transcripts of conversations on a video conference. So this is speech, not me writing prime text.
Absolutely. All I wanted to clarify with you is this.
They mean the same thing.
They mean the same thing. Certainly from a legal perspective, any contribution to a harm that is more than de minimis will be a material contribution. So should we understand that it's your view that sickle cell trait made a material contribution within the definition that I've just read to you, but all the same you consider it was a minor component or a small amount?
Yeah, and I would say, and I will stick with this, that I think probably the sickle problem in his lungs accelerated the moment when he died, but it would have happened anyway.
Can we look at paragraph 33, please? I'm asked whether the sickling of cells I saw in the histology fits with respiratory arrest and then a cardiac arrest. Oh yes, to the extent that one can pathologically distinguish, I think that's right.
This is all about how sickling causes a major organ to fail, okay? And it's and what I'm really saying here is if it contributed at all, which I believe it did, then it did it through respiratory arrest or respiratory malfunction, not primarily cardiac malfunction, which would have followed on later from respiratory malfunction. As I said, I've said several times that even in sickle cell disease, the heart is not acutely affected, not like that.
We've heard evidence, Professor, that the police officers following Mr. Bayo's collapse couldn't find a pulse and started CPR, but when the ambulance arrived and applied the ECG pads, they got a trace.
That's normal in resus, yes.
And when Mr. Bayo was taken to the hospital, it was a very short journey to the hospital,
Yeah.
he was found to be in respiratory arrest, but very quickly went into cardiac arrest. Would that sequence fit with what you saw in the pathology, the respiratory arrest followed by a cardiac arrest?
I think so. The whole business about acute events going around time of death and in resuscitation is actually very confusing. You made it sound very simple. It actually is much more difficult, I think, necessarily to tell the difference between these things going on, respiratory versus cardiac. And even in A&E medicine, it's often rather unclear which one is primary. But they're certainly linked.
I'd like to move away from your report and indeed from the statement and return to something that you said in your report, which was that there's no doubt that the vast majority of persons with HBAS who undergo life's daily stresses do not suffer sickle cell crisis. What I would like you to do is to help the chair to understand the impact that the trait may have on a person who's subjected to a level of stress that goes beyond the daily norm, but is perhaps not at the level of military training in a desert or extreme exertion under marathon conditions or similar. And I'd like to tell you about some of the evidence we've had about the events of the morning of the 3rd of May of 2015, which I'll do in short chapters and then simply invite your comment. So we've heard evidence that Mr. Bayo was a black man in his early 30s. He was 5 feet 10 inches tall. He was 12 stone 10 in weight. His BMI was 25.6. He was
Sorry, 25.6.
25.6.
Yeah,
He was in good health.
Yeah.
He had sickle cell trait, although there was no mention of it in his medical records. He did not have the disease. Absent any source of stress, would you have expected Mr. Bayo to develop sickling within his organs?
No, not at all.
We have heard evidence that in the early hours of the morning, overnight or in the early hours of the morning, he had taken MDMA and alpha PVP. He also used the bodybuilding steroid nandrolone, and nandrolone, at a level consistent with recent administration, was found in his urine. At the time of his contact with the police, which was shortly after 7 o'clock in the morning, we've heard evidence from a psychiatrist that he was in a state of drug-induced intoxication. So can I ask, in your opinion, whether you would expect the intoxication alone as a result of these drugs to have caused sickling?
No, no. And the drugs he was taking, these are difficult ones to. I mean, you've had all this, I'm sure, from people far more expert than me. There are easy drug intake where you can measure things in terms of levels and concentrations in body fluids and draw a reasonably robust conclusion. But with the sort of medications we're talking about here, there are no such sharp cut-offs. It is subjective in terms of interpretation.
Yes.
Yeah.
Yes. We heard evidence that at a point in time after he had taken these drugs, but before he met the police on Hayfield Road, perhaps between 6:30 and 6:45 in the morning, he had a fight with his best friend, in the course of which he punched his friend, chased him with a washing line pole, pushed him to the ground, got on top of him and, I quote, threw a good few punches. A witness to this attack said that it lasted about 2 minutes. Would you expect a fight, such as I have described, to have caused sickling?
Not a fight lasting only 2 minutes in someone with sickle trait, no.
We have heard evidence that after the fight, but again before he met the police on Hayfield Road, Mr. Bayo was chasing cars, walking briskly, walking with purpose. He had a knife. A number of calls were made to the emergency services. Would you expect that level of activity to cause sickling?
No.
We've heard evidence that the police arrived at Hayfield Road at about 7:20 in the morning, at which time Mr. Bayo was walking along the road. He no longer had a knife. He was approached by the police. They shouted commands and they sprayed him with CS and Pava spray, which apparently had no effect on him. Would you expect that to cause sickling?
No.
We've heard evidence that Mr. Bayo then chased a female police officer across a roadway and struck her to the back of the head, causing her to fall. He may then have stamped on her back with full force as she lay on the ground. There's a dispute as to whether or not that happened. But would you have expected those actions, a short run, striking an officer and possibly stamping on their back, to have caused sickling?
I don't think so, but you're getting beyond the level of what I actually know, as I'm sure you appreciate.
Mm-hmm. We then heard evidence about the restraint. This involved Mr. Bayo being struck to the head with a baton 2 or 3 times, struck to the body or the arms another 2 or 3 times. He was then taken to the ground in what has been described as both a shoulder charge and a bear hug. He was brought to the ground quickly, where he was restrained by several officers. He struggled against the restraint, did a press-up to get the officers off him. The weight of one officer, we've heard some evidence that one officer was lying across his upper back. The officer in question was 25 stone in weight. He was, in the course of the restraint, handcuffed to the front and leg restraints were applied to stop him from kicking out. He then became unconscious and subsequently stopped breathing. Would you expect a restraint such as the one that I've described to you to cause sickling?
It could.
Are you able
Because
to,
it was
sorry.
impeding his respiration. This gets down to the oxygen business.
So of the 4 considerations that you told us were relevant, hydration, concentration, oxygen and acidity.
Temperature. His temperature must have been raised at that point from all that physical exercise.
And you said the restraint, and we've heard much about the struggle against the restraint being perhaps as important as the restraint itself, may have had an impact on respiration, and that could cause sickling.
And also, for the muscular activity will presumably produce some lactic acidosis. Tell me, was he ever categorized as having excited delirium?
That's not a question that I would want to be drawn into. I think I would prefer to...
No, I don't either, because its definition is very difficult.
Okay. There has been evidence led in the inquiry around excited delirium, but I think it's best that we stick with,
I'm with you on
your
that
area
one.
of expertise. So I'm interested in how the restraint impeding respiration might have, or could have, I think is the word you used, cause sickling. Is it to do with the oxygen and the hypoxia that you referenced as being one of the 4
yes,
things?
it's multifactorial. It would be hypoxia plus acidosis from lactic acid coming out of the muscle and from inappropriate metabolism. Yeah.
So hypoxia and acidosis, and these could have caused sickling.
But the other thing, I don't know whether you made reference to it, and I can't remember any details, is whether his airway was obstructed.
So, and if there had been any obstruction to the airway, what would the impact of that have been from the perspective of sickling?
Well, it could have precipitated, but more importantly, it kills you faster.
From the description of the restraint that I provided to you, are you able to say at all at what point during that sequence of events sickling would likely have commenced?
No, you can't. I'm sure in this case it developed a bit during that.
Thank you, Professor. Sir, I'm about to move on to an entirely different chapter, and it's a little early, but I wonder if this might be a convenient point to break.
No, and we'll sit at 1:55.
Obliged.
Okay.